In this presentation, I will be demonstrating suctioning the tracheostomy tube followed by trach care. I have all the supplies I need for both procedures, but I will begin with suctioning and then roll right into cleaning the tracheostomy tube and site and so on. Beginning with suctioning. Suctioning is always done based on need and not based on a schedule. So patient is showing signs and symptoms that his airway needs to be cleared. I have my kit. I have to think about PPE because there is a high risk for splash. So I have a mask with a face shield, and if prudent for this patient, I could also wear a gown to protect my clothing. I have some saline that I'll be using throughout the procedure, and as I said, I have the kit. So then I'm going to go ahead and think about my environment, setting up my patient and my environment, and to help me to remember all points, I think of POSS, P-O-S-S. So I want to begin by positioning the patient, and actually the patient is in pretty good position here, but the patient needs to be in a Fowler's position, and I'd like the pillow to be slightly behind the shoulders so that when I go ahead and do some trach care, I can have better access to the neck, and also it exposes the opening to the tracheostomy tube a little bit better. So as long as it's not contraindicated, I can just move the pillow down slightly just to put the head in kind of a sniffing position. So that's P position. O is oxygen. So because when I suction, I remove oxygen along with the secretions, I want to offset that by giving him additional oxygen for the suctioning procedure only. I have to be sure to turn it back to my ordered setting after he recovers from the suctioning. But for the procedure, I'm going to go ahead and I am going to turn this up to 100% and let him kind of build up his oxygen stores so he doesn't, as I said, bottom out as I'm suctioning. And then in addition to that, I want to put a pulse oximeter on him so that I can monitor how he's tolerating the procedure. So POS, suction source. So I want to get my suction source ready. And I want to have this about at 100 to 150 millimeters of mercury. So I would go ahead and I would set it accordingly, making sure that it is where I need it to be, and then I want to put it in reach. And then the final S is saline, so I want to get my saline ready so I'm not finding that it's so tight I can't get it off once I have my sterile gloves on. Just loosen your saline bottle. So P position, O oxygen, S suction source, and second S is saline. Clean gloves off. I'm going to wash my hands. I would next put on my mask with the face shield, but for the purpose of this video, I am going to verbalize this step. This would go on, and if needed, down, and then I would go ahead and open up my kit. And in terms of how your kit comes supplied, there is a pop-up water basin, and sometimes we're going to find it in the fold of the kit, which is the case here, is that it's kind of hid underneath this outside fold, in which case I'm going to manage it with my clean, ungloved hands, and I just pop it open, but I have to be especially careful not to touch the interior of the basin because that's where my saline is going to go. Sometimes we'll find that the basin is underneath the sterile gloves, in which case we have no choice but to glove and then manipulate it. But in this case, I'm going to go ahead and pop that up and have that ready to go. And then I will go ahead and get some gloves on. So the gloves that they give you in the kit are kind of the one-size-fit-all. If you don't care for these gloves, you can certainly just bring in a pair of sterile gloves and use those instead. Okay, once my hands are sterile, then I'm going to go ahead. I'm going to pull out my catheter, being careful to control it. I'm going to coil it in my dominant hand which is my right hand. And I'm going to leave the regulator poking out like so. All right. At this point, I'm ready to contaminate my left hand, my non-dominant hand. I'm going to pour some saline, and we'll presume this is a brand new bottle. This field is no longer in use. And so now then, I will go ahead and I will attach to my suction source. So now the regulator coming out of the suction kit is sterile, but at this point when I attach to the suction source, it becomes the divide between the sterile and the non-sterile. And I manage it with my non-sterile hand. So the suction catheter must stay sterile, and here beyond it is non-sterile. I'm going to go ahead and I'm going to check the suction to make sure that it is working. When I'm doing this, I am simultaneously lubricating the catheter. For an artificial airway, this is all we need. We don't need any water-soluble lubricant at all. So I see that my suction source, my suction catheter is working just fine. And the additional oxygen that I've given my patient has brought up his pulse ox very nicely. It is up toward 100%. So now I'm getting ready to suction. I'm going to take off his trach collar. I go down, being very careful not to touch my fingers, to the tracheostomy tube, and being very careful not to apply suction on the way down. I'm going to advance the catheter until my patient coughs. When he coughs, then I'm going to go ahead and I'm going to rotate the catheter on my way out, holding continuous suction. As soon as I come out of the airway, I want to immediately give him his oxygen back so that he can start replenishing his oxygen store. So that's my priority. Get the oxygen back on your patient. At this point, I'm going to go ahead and clear my catheter. While he is recovering, I can make sure that he's doing okay, watching his pulse ox, watching his pulse, watching my patient, and I'm going to give him about a minute to catch his breath and recover. Based on how much secretions I got from the airway will determine if I need to go down and take another pass. I can take up to 3 passes per any suctioning procedure. However, remember that ultimately you want a patent airway, but try and limit it to no more than 3. If I really didn't get much out, then I don't have to go back down again. So only go down as much as you need because this is very taxing to the patient. So assuming that a minute has gone by, he's kind of settled down here, pulse ox is back up, and I'm going to take another pass because I got a fair amount of secretions the first time through. I've already cleared my catheter, so now I'm going to go down again. Again, no suction on the way in, and I'm going to go until my patient coughs, and then I will start continuous suctioning, rotating the catheter back and forth to kind of pick up as much secretions as I can on the way out. Priority is patient. Give him his oxygen back. When I am suctioning, I want to make sure that I don't suction for longer than 10 seconds. So as I'm withdrawing the catheter from the airway, make sure that you're not staying down there too long. I have a 10-second window for suctioning. Beyond that, I'm going to cause the patient to become too stressed and hypoxemic if I stay down too long. So again, based on how much I got out, I will make a determination if I need to go down another time. So I will say again, I still got a fair amount. So I clear my suction catheter. I wait for a minute. I make sure the patient has recovered, the pulse ox has recovered. He's nice and calm, and I'm going to take one more pass. And again, no suctioning on the way in, advance to a cough, and then apply continuous suctioning and rotate the catheter on the way out. Okay, priority is patient. Give him his oxygen back, make sure he's doing okay, keep an eye on his pulse ox, on his pulse, to be sure that he is not decompensating as a result of the suctioning. So at this point, I will let him recover, and I am done suctioning, and I expect to go right into trach care. So because of that, I'm gonna go ahead and I am going to take out the split gauze that is presently underneath his trach tube, and I'm going to take a look at that, and it apply code, color, odor, drainage, edema and erythema. So I'm looking at the color of the drainage, noting if there's any odor coming from it, really looking at the amount. And then edema and erythema, I'm going to take a look at the opening in the neck and see if there are, if there's redness, excoriation, or anything along those lines. With that, I can go ahead and I can take my gloves off, and just to contain any microorganisms that might be here in this catheter and dressing, I'm going to go ahead and close that up into my gloves. And then don't forget, I need to turn my oxygen down. So I want to bring that down to his ordered rate. Now that he has kind of calmed and his pulse ox is back up, suctioning is over, and with that I'm ready to roll into trach care. Now I'm ready to move into trach care. I would continue to have my mask and face shield on. So I have my trach care kit. The contents of my kit are noted on the cover, and I would have to add to them accordingly. And there are several things that I need to prepare in addition to what's in this kit. So this kit is not all inclusive. And I've brought them in, and I will make note of them as I open them onto the field. All right, so I open this up. The first thing I see at the top are my sterile gloves. These are really not going to serve me well in this procedure because I have so many additional supplies to open, and I cannot open supplies with sterile gloves on. So in this case, I'm just going to take these. I'm going to reach in with a claw hand and remove them and put them off to the side. And then I'm going to go ahead, and there is a drape in here, and I'm going to be careful to manage it by the 1-inch border. And so I will pull my drape out and put that down first. Now, because the entire field has landed on the horizontal surface of the table, it's my preference to move it over so that I have room for my basin beside it in the corner closest to the patient. That is an ideal position for your basin, but it's not mandatory. But I'm just going to manipulate things so I can do that. If part of my field had fallen down off the horizontal surface of the table, I would not have that latitude because, as you know, anything that falls below is contaminated, and moving the field around would bring the contaminated area onto the table, which I cannot do. Okay, all right, so now I'm going to go ahead and take the contents of my kit, and I'm going to dump them on my field, and then my basin is here beside, corner closest to the patient. And then I will continue with the supplies that I need. I need a new inner cannula. My patient has a disposable inner cannula, so this is the new one that I will put on today. I have a tea sponge. There is one in the kit, but I'm opening up an extra one for good measure. And then I need some gauze for cleaning around the site. And so I could do that in a couple of ways. There are 4 gauze that come in the kit. I'd like to have 4 additional so I can open up the 2-ply ones, individual packages like so. Or I can open up a tray if you have it, which is very nice because all of your gauze that you'll need are in one flip. And so that will cover the gauze that I need. And then I need some Q-tips, cotton tipped applicators. The kit comes with 2. I want to have really for the purposes of the lab in this demonstration, I want to have at least 4. I can have a couple extra for good measure. In the hospital, all of your supplies will be determined by what the site looks like. So this is really a minimum number of supplies that you'll need, but take a look at what that site looks like and then adjust your supplies accordingly. In the hospital, you'll probably need more Q-tips than just 4. Okay, I'm gonna drop those on my field. And then I also have a new Velcro tube holder that is not sterile, so that stays off the field. And then I think that completes the supplies that I need. And now I need to palm the label, going to lip, pour, and recap. Now I'm ready to put my sterile gloves on. Kind of have to put myself at an angle here because I don't want to overlap fields. The sterile wrapper that the gloves are on is a sterile field unto itself. So just remember that we can't overlap our fields. Now that I have 2 sterile hands, I'm going to go ahead and I am going to organize my field. Remember, as you're organizing your field, you have about halfway that you can reach over without compromising sterility. And so if I need to access some things that are a little farther back, remember to use your sides, kind of approach from the sides to prevent yourself from reaching more than halfway. So I have all of my gauze here for cleaning. I'm going to stack that up and get that in order. My Q-tips, my split gauze. This is what I'm going to use at the very end. So I'm going to just kind of reach around and put it towards the back. And then I have some supplies here that I won't use, scrub brush and pipe cleaners. Those are used when we have a replaceable inner cannula. And then I have some more gauze that comes with the kit. I have my disposable inner cannula. And then I have this twill tape here. This is a type of trach tie, but I'm going to use the Velcro. Okay, patient's still doing well. Keeping an eye on him. Pulse ox looks good. He's resting comfortably. So I'm going to take a minute and I am going to prepare the supplies that I need for the cleaning procedure. And I'm going to do that in advance. You don't have to do it this way, but this is one option where, because I have a multi-compartment tray, I'm going to go ahead and I'm going to moisten my supplies and then I'm going to store them in the tray so that when I start cleaning, I have everything ready to go, and I can just take my supplies and go right into the cleaning. If I wanted to moisten and clean as I go, that is a perfectly fine option. It's just whatever the nurse's preference is. But I'm going to go ahead. You'll notice I'm making these little kind of parachutes where I take the four corners and gather them up, and then I get the bottom moist with saline and just putting them into this tray in the spare compartments so that once I start, I can just move right ahead with the cleaning. Okay, so I want to get together, I'm going to put together about 8 of these little parachutes. My Q-tips, I'm going to get those ready, or I could always dip those right before I need them. Now you'll notice I have some water on my field because I have a protective plastic layer. That's not a problem. If this were not waterproof, that would be a strike through and I'd have to set up a new field. Okay, so taking a moment of pause because I'm ready to contaminate my non-dominant hand, and then the balance of the procedure will be done one-handed. I have everything that I need to go here, so I'm going to go ahead and I'll let my patient know I'm getting ready to get started. I'm going to take the oxygen and I'm going to put it off to the side in what's called a blow-by. So looks like this side might be a little easier. And so what I want to do is actually have the oxygen come across the opening in a blow-by manner so that the patient is breathing in some of the oxygen while it's off the tracheostomy tube. So it's blowing by the opening, increasing the FiO2 across that area. Okay. All right, so now I begin the procedure by removing the inner cannula. This is typically changed daily. I set up a garbage bag already, so that goes into the garbage bag. Now, I could go right in and put the new inner cannula in. However, I am going to opt to clean the faceplate first because the inner cannula has wings on it, and sometimes the wings will catch the gauze. So I'm going to begin by cleaning in kind of a half moon fashion the faceplate. Sterile hands to sterile supplies. I'll clean and discard. And I could use, again, as many as I need to. Now the faceplate is an area, because it's plastic, we can let it air dry, and most especially if we're kind of short on gauze, we want to do that. But if I have plenty of gauze, I can go ahead and dry in the same way. Always using my sterile hands to manipulate my sterile gauze and my sterile cleaning supplies, and the other hand just to assist with moving any parts of the trach. Okay? All right, so now that that's done, I'm going to go ahead and I'm going to take my new inner cannula. I'm going to manage it by the part that is going to be external. I never want to touch the part that will go into the opening. So the winged area is the part that I want to be managing. Okay, and I want to make sure that I'm putting that in there very gently, that I'm not pushing it in, because that would be very painful for the patient. So that part is done, and now I'm ready to clean the stoma. Okay, the stoma, we start with the upper border, and so I have to be very careful when I'm managing The tracheostomy tube, I can't pull it. I have to just tip it back and forth in order to get behind it. Okay, so it's kind of like teeters a little bit. So I can just teeter it, but I cannot pull it from the airway. Okay, we could risk decannulation in that way. All right, so I do a half moon. For the purposes of the demonstration, I'm going to do one wash and one dry. In the hospital, we would likely do multiple. I do the upper border, and then I'm going to do, just moving this for a moment, the lower border. Wash and dry. Keeping the sterile hand sterile, I'm going to move my oxygen back up. And now I have the peristomal skin. Upper border. This is where it gets tricky because it's kind of easy to bump the back of your hand. Really, you just kind of have to do the best you can depending on the patient's anatomy. And then here's my dry gauze. And then we do the lower border. This is where you're really going to find a lot of secretions because of gravity. So I could use an extra one and go another step further. And then I would go ahead and dry. If I needed to dry a little better underneath my faceplate, I could gather up 3 of the 4 corners and leave one corner like so, almost I call it a little tail. And then I could also guide that underneath to try and clean a little better underneath the faceplate as well, because keeping your site clean is very, very important. Clean and dry, excuse me. Keeping it dry is very important. All right, so now that I've done that, the sterile portion of the procedure is over. And the reason for that is because the next step is I'm going to change this Velcro tube holder. Take a look at your patient. If they need a little break, we can give them a little break, let them breathe in some oxygen. And then we're going to go ahead and get our Velcro tube holder. And so we have to take this off again. Critical element is we have to put the new holder on before taking off the old one. And the reason for that is it has to be secure at all times. Everything we're doing here is causing irritation and the patient is coughing all the while. So if we loosen up the holder and the patient coughs, he could cough his tube right out. So we have to make sure we have the new one in place and then remove the old one. If the old one is particularly soiled and you don't want the two coming in contact, then you would need to have a second person in the room, and that second person would be holding the airway in place for the period of time that it was not being secured by a tube holder. But without a second person, we have to keep that first one in place, secure the second one. So I'm going to just kind of put it behind his neck to gauge about how I want to adjust it. Okay. That looks good. And then I'll go ahead, again, being careful not to pull on the airway. These little eyelets on either side actually have a little bit of give to them. So I'm going to pull the Velcro through. and get that in place. I can certainly go to the other side if I need to. Try to see what I could do from this side. Okay, and then I check to see, does it feel the way it should? Does it need to be a little tighter? I want about 1 to 2 finger widths. So I want it to be snug without causing pressure. I'm going to take off the old one now. Okay, and this is gets thrown away. And I'll double check. I think I could still snug it up just a little bit, so I would make it just a little bit more snug. And then last but not least, I put on my new split gauze. Now I realize that I do not have sterile hands anymore, so what I'm going to do is I am going to manage my split gauze by the edges, so that I don't touch the split that will communicate directly with the opening in the neck. So in this case, I'm going to pull this down, and I'm going to bring this up like so, and then tuck it underneath. And once it comes to the other side, we can grab hold of it and pull it through, okay? Like so. One more check on the holder. All right, this is the pilot balloon. We want that front and center where we can see it. And then we want to give him his oxygen back. Checking his pulse ox all the while, making sure that he's tolerating this procedure. And that concludes trach care.